getting started on reducing waste. And my name is Ella Nuttall. I'm Head of Strategy at NHS Elect, and I'm going to give you a brief intro of what to expect today before handing over to Katie and Claudia. Welcome if you're just joining us. A few housekeeping points. So as mentioned, the webinar is going to be an hour and a half. We will make sure to finish on time. We are recording this webinar, so if anyone's unable to join, they can access that, but you can also access it afterwards. It's going to be saved on the Teams channel that you should have access to. We're also going to be circulating the slides afterwards, so don't worry about writing anything down. We are going to email them to anyone who has signed up to the webinar, but we'll also put them on the Teams channel in the same place as the recordings. We've got some time scheduled at the end for Q&A. So if you've got any questions throughout and you don't want to forget them, please just put them in the chat and we'll make sure to come back to them. We're also, at that point, will facilitate a kind of hands up discussion. So if you want to verbally ask any of your questions, we'll also have that opportunity in that section. And finally, we're going to be using Slido to capture some of your thoughts at certain points. So don't worry if you're not familiar with it. But if you do have a phone handy, that will be useful, as you can access it by scanning a QR code that we're going to provide. But we'll also be sharing a hyperlink in the chat. So don't worry if you don't have a phone. In terms of the agenda, so this webinar is divided into 4 main sections that are going to guide you through the key aspects of starting your nitrous oxide waste reduction project. In the first section, we're going to explore different governance structures available to support your project to ensure you have a solid foundation for decision making and accountability. Next, we're going to look at broader stakeholders involved in the project, their motivations and interests, and discuss how to engage them effectively. We're then going to demonstrate 3 resources that are available to support you to manage these upfront parts of your project. And then finally, you're going to hear a couple of case studies from Laura and Max on their respective nitrous oxide waste reduction projects. And they're going to share insights on common challenges at this stage and also any advice they have to offer. And we'll then, as I mentioned, have an open discussion where you can ask any questions and share your thoughts. As you would have seen in the comms about the webinars, NHS England, NHS Elect and UCL Partners are running these series of webinars from January to March to support NHS trusts to design and implement nitrous oxide waste mitigation activities based on the nitrous oxide waste reduction toolkit, which is going to launch early 2025. So you've got colleagues from NHS England, NHS Elect and UCL Partners on the call today who are going to be presenting. And then we're also joined, as I mentioned, by Laura, who's an Associate Chief Pharmacist at King's, and Max, who's an Energy Manager from Cambridge University Trust. And they're going to share their case studies a little bit later. If I can just ask everyone to make sure you're muted, just so we don't have any background noise. Thank you. As a reminder, we've got 10 webinars in this series. 3 are pre-recorded, and this is the first live webinar. So please sign up to any of the other ones you're interested in if you haven't already. And as I mentioned, there will be recordings available for all the live ones, even if you're unable to attend. And the nitrous oxide in the NHS Part 1 and 2 pre-recorded webinars are now available on the Teams channel. So if you haven't had a look and you're interested, please do take a look. And Angeline's going to post them, the links to them in the chat as well. In addition to the 10 webinars, we're also having 2 general drop-in sessions, which are scheduled for the 20th of February and 20th of March. And this is a space where you can bring any general questions or challenges related to nitrous oxide waste mitigation that you have. And just in terms of how these webinar series have been designed and structured, so they aim to sequentially follow the nitrous oxide waste reduction roadmap that you can see on this slide. So starting with ensuring understanding in the context of the NHS and moving to initiating efforts and setting up governance, which is what we're going to be covering today. Then on to ensuring supply of gas is aligned to clinical use and the continuing optimization of systems. So before we dive into the content, we just like to understand which stage you would say your trust is currently at in terms of your waste mitigation projects. So if you've got a phone handy, you should be able to scan the QR code that's now on the screen. Angeline is also going to pop in the chat a hyperlink, so you can access the Slido via your computer as well. So you can see on the slide, there's kind of 6 options. So if you could pick which stage you would say is closest to where your organisation is currently at. And this is really just to get a feel of who's in the room. Nothing is going to be done with this data. And irrelevant what stage you're at, there's obviously value in understanding how to structure your project. So there's something relevant for everyone today. Great. Okay, so I can see we've got a few people not started, some establishing governance. Great, so a nice range happening. Thank you. And always reassuring to see people are able to access the Slido. If you do have any problems accessing it, please also just feel free to put your answer in the chat and we can collate it in as well at a later point. Great, so I'll just give it a minute more. So if you're just joining us again, you can scan that QR code with your phone or follow the Slido link that's in the chat. And it's just understanding what stage your organisation is at currently for your work to get a feel who we have. Okay, great. Thank you. I will move on. So in terms of the purpose of today's session, so it's designed to equip you with the knowledge and skills to kickstart your nitrous oxide waste reduction project. And the information that is going to be shared has been drawn from trusts across all over the country, what they have set up that supported their projects and what they've changed or improved as they went along. And we're going to focus on how to set up governance, gathering your team, and taking initial actions that will lay a solid foundation for success. And even if you've already set up your project, we hope it will also allow you to reflect if there's anything you could strengthen skill or improve on next time. So finally, before I hand over to Claudia and Katie, we just want to do one more Slido. So what we're wanting to do is a quick pre and post assessment to establish whether this webinar has in fact helped to improve your confidence. So if you're happy just to rate your current level of confidence at initiating nitrous oxide waste reduction projects, that would be great. And I should have said all of your Slido responses are anonymous. So please feel free to be open and honest. And thanks to those that have already. So again, we've got a bit of a range of confidence. Great. Thank you, everyone. So I'll just give it a minute more and we will ask you to repeat this also at the end of the webinar, just so we can do a little comparison. Okay, thank you, everyone. We'll hand over to you, Katie and Claudia.
Thank you, Ella, and nice to see everyone. So as Ella mentioned at the start, I work at UCL Partners with Katie, and we are in the climate implementation team. So we've been working on developing kind of a really broad understanding of nitrous oxide in the NHS and what to do. And just kind of noting some of those responses in the Slido, that there's some people who haven't got started yet on their nitrous oxide work, and there's some people who are not really confident in how to get started. And I just want to kind of reiterate what Ella said there, that we have 2 pre-recorded webinars, which are only 15 minutes long each. And I think that they give a really good insight into kind of what we're going to cover, what the activities are, you know, how nitrous oxide works, just give you that foundational understanding. Hopefully it's a really good 101 for how it works and what we are kind of guiding people to do based on our experience working with NHS trusts across the country. But what we're going to do today is more so focus on how do you actually get your project started? What is the right way to go about this? And it's going to be different in every trust. And often what we've heard is this is what people wish that they'd done. A lot of trusts have done this work, and they're now they've now completed a lot of waste reduction. They've saved lots of carbon emissions. They've saved some money, and they have paved the way for other trusts to now go forward in a bit more of a structured way and have the right people involved from the get-go. So I just want to kind of set that as a bit of context. Next slide, please, Katie. So in that kind of from the learning that we've had from trusts across the country and listening to those experiences, these are some of the things we've heard directly from them. And I just want to acknowledge some of these challenges, and they might be some of the challenges that you're coming across if you're trying to get started. The first one is that there's often an individual champion who's really trying to get this going. That's a passionate anaesthetist, a sustainability lead with time trying to do this kind of work all over the organization. And, we've seen lots of different clinicians and professionals being champions of this work and trying to drive it forward themselves. And sometimes they've been really unclear how they move this work forward. So we want to acknowledge that there might even be some of you on the call today who fit that bill. And we want to let you know that, you can do this and you can get it done, and other trusts have been successful in doing that. Another thing that I'm sure many of you have experienced is the budget constraints. So there's lack of funding for large scale changes. And hopefully throughout this series, we can start to address how you can be the most effective with your funding and also save money through this project. We know that there's complex organisations. There might be multiple sites, there might be multiple hospitals within your trust, and multiple different clinical areas. There's also different understandings of how nitrous oxide works and how it should be supplied and what is needed, and that can make the progress of these projects be a bit slower than we would hope. And hopefully some of the messaging we kind of explain in this webinar can help unblock that complexity and those differing of opinions. There's also medical gas committees who have a major part to play in this work. We've often got pharmacists, estates and facilities, and other clinical leadership and other estates leadership in those groups, but they can sometimes be hard to access, and the meetings can be intermittent and they can have other things on their priority list. So we know that that's another challenge. And then finally, it's kind of that leadership generally, capacity and approvals for staff and senior leadership to say, yes, go ahead with this work. So hopefully throughout this whole webinar series, we can help to unblock some of these challenges by giving some guidance. So if you are one of those individuals or a small team of people trying to get started in this area, the thing that's worked for other trusts is that go to the areas that have an appetite for the project and have interest. Start where there's already a little bit of momentum. There's some statements. There's a statement recently by the Royal College of Anaesthetists saying that medical gas pipeline systems are not required anymore, and that they encourage and kind of are behind this project, and using things like that can help to drive forward this agenda in spaces where there might be people that are interested. We also suggest that you could start with decommissioning work, so you can find the spaces where there's no longer any gas needed. So if it's a clinical area that used to be used for something else and now has changed and there's still supply being sent to that area, there's no need to have it anymore. So you can start the momentum just by capping off those areas. And then finally, take it one hospital at a time and one service at a time. So this project can be incremental and it can start small and kind of scale out. This is just to kind of preempt that the rest of the webinar goes into quite a lot of breadth and depth, and the rest of the series does as well, and it might feel a bit overwhelming. So I guess this is a reminder just to say that you can start small, it can be led by one person, and you can make progress just in a small space and see progress in those, I guess, easier areas. So I guess remind yourself of that if it starts to feel like we're telling you that you have to change the whole system at once. Yeah, so just want to start with that. I'm going to hand over to Katie, and she's going to speak through the governance structures and project team kind of setup that we have found works well.
Thanks, Claudia. Yeah, indeed. So my name's Katie and I work at UCL Partners, and I am supporting on this series, but in a previous role, as Laura can attest to later, I worked for nearly 2.5 years at King's, project managing the nitrous oxide waste mitigation work. So it's been hopefully useful to thread some of that experience into the next few slides as well. I think one of the things that's come up, so as Claudia said, these slides that I'm going to go through now, they feel they may feel a little bit prescriptive. That really isn't the intention. I think it's just to share some of the key themes that have come up time and time again from those who have done this work. And one of those things is governance. That word governance. So basically, how can this work keep moving forward? How can decisions be made? Who needs to be involved in taking them forward? And how are problems dealt with, because problems and issues are inevitable to creep up in any work, and nitrous oxide waste mitigation work is no exception. I think there are many different approaches, probably as many as there are NHS trusts or indeed perhaps NHS hospitals. Some work has had, and you'll see these three key players on the screen here. So some work has had executive leadership on board right from the beginning. Others have had established medical gas committees driving the work. Others, as Claudia just said, individual champions that have started in their spare time to push through changes and to push for a wider acknowledgement or awareness of the need to do this work. And I think for many it's been quite inconsistent. So perhaps it started with an individual, and then as that awareness was generated, the medical gas committees were more and more involved, and then perhaps that led to sort of executive leadership and awareness at that level. But I think no matter the approach, these three key players don't change. So the people on the ground, the doers, the people doing this work, the people facilitating the changeover of different cylinders, and the people that are actually working to improve the day-to-day, that the project team, that's what we're going to refer to them here as, the project team. But we know obviously that teams are not necessarily as structured, and that maybe that it's more about noticing individuals across different parts of the system and them coming together and forming that team. The medical gas committee is another key player, monitoring, enabling the work, and of course the executive leadership that has been seen in some cases to unblock any big problems that might come the team's way, and support at the strategic level. So from just to throw in a little bit of my experience, when I started doing this work, I can't remember when it was, 2022. I didn't know, I worked in quality improvement, so I wasn't in sustainability, and I wasn't clinical, and I also did not know of the existence of a medical gas committee. So I think it's just, if there is anyone on the call who is just starting out this work who isn't necessarily an expert, because how can we all be experts, right, in this system? Hopefully what you're about to hear is useful, even if it's just a good recap of who are these people that need to be involved and what could their role be in your project work. So starting with this graphic, so this is quite a simple graphic, but really what it is supposed to do is just to show those three key players, those three key parts that are seemingly consistent in all of the trusts that have done this work. So those three: executive leadership, the medical gas committee, the project team, and the fact that they will communicate between each other pretty often. But of course, there are also wider stakeholders. Claudia is going to go into a little bit more detail later on about who they are. And this graphic is helpful in understanding who these people are. But of course, there is crossover. So people who sit in a medical gas committee might be involved in delivering some of the actions in the project. And there's going to be wider stakeholders that will sit in the medical gas committee and maybe be, at times, if you're rolling out changes over time, be part of the project team too. This is simply just to get a sense of what that governance structure could look like for you. So if we start with the executive leadership, I think probably two useful things to share at this stage is that all trusts and ICBs will have net zero leads. So executive leads who are responsible, for example, for the green plan strategies and every trust's journey to net zero. And the fact that executives can act as senior responsible officers for projects, that's what we've seen in some cases for different trusts. And that looks like the following 4 bullet points. So providing strategic leadership, like I mentioned, setting that vision for the net zero strategy, what goes into the trust green plan, and serving as a champion to raise awareness of this work, to communicate this work, and to celebrate it as well, to help with momentum and to help with communication. Unblocking any major issues, any significant problems that might occur in the project work, having that authority to intervene and remove any obstacles that otherwise might be impeding progress. And also related to that, being the governance leadership, being that ultimate escalation point for any issues, and that they might be raised by a project team, by an individual, or indeed by the medical gas committee, who will also likely to be involved in and invested in the work. And of course, a little bit about external accountability. So I think this probably leans more into what are the interests and what are the motivators at this point. So, ensuring that gas is still available for the clinicians and the patients that need it, legal requirements, any compliance with regulatory frameworks. And I think useful to share how they have been involved in some projects. So advocating for the project itself, assigning resources, addressing the challenges, like I mentioned before, spreading the success and sharing the outcomes, whether that be at the board level, or perhaps if you have sustainability program boards at your trust, evidencing the work there and enabling, enabling some attention and awareness and motivation for teams and often individuals that are doing this work. And so the next slide, each of these key players, so these 3 main bodies or individuals in these slides, we've got these actions. We're not suggesting that you write these down. We've actually got a resource that you'll see on the top right-hand side, a key action checklist, which Claudia is going to talk through later. And what we've done is we've assembled all the different possible actions based on what trusts have done in this work, in a long list, depending on what stage the project might be at. So, for example, this would be getting started, so gathering a team, putting together a governance structure. And we've listed those out. And you're able to take that away and edit it and use it for your own purposes. So anything that we're saying in this webinar and also the webinars to come about implementing portable cylinder systems or navigating engineering requirements and all the different actions that you might need to take are all in that spreadsheet, which we're going to go through later, if that's helpful to know. So, of course, identifying who your trust net zero lead is a good thing to start with, as well as thinking about what could work best for establishing risks and issues to an executive sponsor to a net zero lead, if you can. And I think that lots of trusts have simply used the risk escalation processes that already exist to share those risks and to communicate like that. So moving on to the Medical Gas Committee. Like I mentioned before, I didn't know what a medical gas committee was before doing this work, but I can share now. So medical gas committees oversee the safe and efficient supply of medical gases within NHS Trust. I'm sure some of you on the call perhaps even sit on a medical gas committee. So if you do and you want to share a little bit about what you talk about, then feel free to do so in the chat. And so really, what we found is that there can be one medical gas committee, and also be useful to hear actually if this is the case for you individually, but there are different setups at different trusts. There could be one medical gas committee across the entire trust. There might be some medical gas committees across hospitals, so per different site. It seems like it isn't necessarily consistent, so it might be worth trying to find that out if you're not too sure, because I think it will likely influence how you might want to roll out a project. So this includes what they're responsible for includes how gases are purchased, stored, delivered, supplied, administered, and their role involves all of those bullet points. So allocating resources, funding, equipment, personnel to support with the medical gas projects and operations. So useful if a team or an individual is looking for additional resource to support with this project work, or understanding who they need to go to answer questions in a specific, for example, clinical area about usage, or an engineer about medical gas pipeline systems. Again, identifying risks and issues, so sitting across that system, right, from delivery to use. So really being able to understand what potential risks, and putting together the right people to put together mitigations for those as well. Agreeing changes, so signing off any changes to the way that gas might be delivered towards the change of infrastructure, so perhaps using portable cylinders instead of a medical gas pipeline. Supporting decisions, so of course, actually supporting the doers, the project team, to enable them to do the work and to make those changes. As well as representing others in the process, so perhaps clinical leads or others who are using the gases, facilities management as well as often represented in the discussions and in the decision making that takes place in the committees. And also, I think a key part of the role is monitoring progress. So tracking any milestones, asking how it's going, understanding any compliance with regulations, and escalating those concerns when necessary. So really understanding how the work is going and being in a position to support it. And I think from experience that from my own personal experience, that it's possible to pursue this work to a certain level before getting the Medical Gas Committee involved. So it's not necessarily like an individual or a small team can't progress forward, perhaps like Claudia said, in an area where there really is appetite from clinical leads to have a think about how to reduce the waste of the nitrous oxide that is sometimes very infrequently used. And again, if you're in the Medical Gas Committee, feel free to share if it looks slightly different for you. But here is a list of the individuals and the roles that usually, from what we've heard from trusts, makes up the membership of a Medical Gas Committee. So I'm not going to read them out, but you'll see a long list there of different representatives from across that system. I think the main point to underscore is that it intends to be interdisciplinary. So it tends to represent that system and those who are involved in both the delivery, the procurement, the purchasing, the supply, and the use of all medical gases, and nitrous oxide and nitrous oxide oxygen, known as NOx, obviously being one of the many gases that the Medical Gas Committee would be responsible for overseeing. Just to go back to my point on monitoring progress and tracking how it's going, a few have used the Green NHS dashboards to do this. I'm sure you have used the Green NHS dashboards to look at the procurement data for your own trusts. So we've just put a couple of screenshots here on the slides, one for nitrous oxide and then one for nitrous oxide oxygen. But we've heard that some medical gas committees that have had the space to review these have mentioned that it's helpful at the start to get a little bit more comfortable with what procurement and what volumes of the both gases look like at a certain trust, to start to build up that picture, to sort of get that general knowledge across all of the people that we've gone through, all of the system, before implementing any changes to it, which obviously would enable the Medical Gas Committee to then reflect back and see when those changes start to be represented on the Green NHS dashboards. There is some instructions for gaining access to the Green NHS dashboards if you don't have access. I'm not sure if it's going in the chat. I can't actually see the chat at the moment for some reason. But if it's not in there, if it's not going in there, we can pop it in after I've finished talking. It's not a problem. And then again, these suggested actions that other trusts have taken. If you wouldn't mind popping yourself on mute if you can, that would be great. And then you'll see here the best thing to do if you're involved in this work, if you're project managing, or if you're the one that wants to get it off the ground, to contact those members of the Medical Gas Committee, find out who they are, and get the project on the agenda as a regular item, using the dashboards perhaps as an opportunity to start asking questions, to start having those conversations. And the last point there, number 4, about the HTMs, the Health Technical Memorandum Guidelines, that's really more of an action for the Medical Gas Committee. That's not really for the project team or one individual. And it's just something to be aware of, that's part of their role, is to ensure that the supply continues and that it complies with HTMs, which we're going to talk about later on. So not in this webinar, but we in future webinars, we'll go into a little bit more detail about what health technical memorandums are. Bit of a mouthful, what they are, and who and when they come into play, mainly for decommissioning medical gas pipeline systems, and the information and the guidance around how to do that safely. And then moving on to the final and arguably most important role of the one out of these 3, which is, of course, the project team, or indeed the individual who is doing the doing. So carrying out the tasks, collecting data, reporting perhaps to the Medical Gas Committee and other stakeholders on how it's going. The ones who are at the coalface of identifying the actual risks and issues that might be occurring across different clinical areas. Speaking directly with the clinical teams, understanding what usage might look like in a specific area, talking to the engineers about the steps needed to decommission a medical gas pipeline system, assuring clinical teams who use the gases and explaining how the gases could still be made available in clinical areas where they are used, and also working through changes to management of cylinders, if that's what required in a particular area. I think when it comes to project management, there is no one size fits all approach. Some trusts, I can say, King's had quality improvement. That was what I did. I know, for example, other trusts, Alifia Shakira and Lothian, also came from an improvement perspective, using particular methods that we'd see an improvement. But that's not prerequisite. Other trusts have had sustainability teams involved, transformation colleagues, clinical colleagues as project managers, but there's no one size fits all, and there's no best practice when it comes to that. I think no matter who the clinician or the corporate person who takes on the role, it doesn't necessarily have to be formalized, doesn't have to be a formal project manager. Leads who make decisions, can coordinate actions and speak. I think the key thing is just communication, isn't it? Speaking to everyone who might be involved, anyone who is interested in and who this affects, and working through actions to ensure that everyone knows what the changes might be. And then in terms of membership, if there is a team that's going to be assembled, it's likely to include a mix of clinical representation, of course, from the areas that use the gases, the medical gas engineers and the porters in the states and facilities who supply the gas, who manage the medical gas pipeline systems, and others, so professionals involved in pharmacy procurement who buy the gases in, and those who are perhaps involved on the delivery side, so perhaps even the supplier themselves. And of course, at the outset, you might not want to involve everyone straight away, because nitrous oxide and nitrous oxide oxygen in a big acute hospital are used in a myriad of different places, and future webinars will list all of those clinical areas. So that's going to be a lot of people if it's a big hospital. And as Claudia mentioned, a lot of trusts that have started this work and finished it, started small, started in one area and focused on the changes there, and then obviously that team reflected the representation of that area before changing it, before bringing more people in, and then sort of snowballing it out from there. And then again, these actions here as suggested things to think about doing at the start of a project. Meeting in person, we at King's, we met in person, and I still remember it really well actually, I don't know if Laura does, but we had a big meeting where we all went round a manifold and we all just took time to think, what actually is a manifold? What does it look like? What do the pipes look like? Where do they sit? Where in the building do they exist? How do you get access? And what happens? And the engineers spoke through it all. And it was helpful just to also have that face-to-face time with people, started to build relationships, and just actually being able to talk face-to-face and understand the concerns, and start to build a good working relationship with each other. And the same goes for obviously visiting the clinical areas too. So the opposite and equal side of the system at the end, one end you've got the delivery through the medical gas pipeline system, at the other end where it comes out, the wards and the clinical areas. And it will be helpful for the engineers to see that, the engineers and the porters who see the manifolds to go up and see where it comes out the other end, and vice versa. And of course, being able to review any available data on nitrous oxide supply in your hospital, and future webinars. So, and we've got some resources that Claudia's going to talk through later, future resources that go into a lot more detail about how you might want to collect data. But the main impetus here, and from learning from all these trusts, is the ability to sort of start acting straight away, and not worrying too much about collecting too much data. But that's where the Greener NHS dashboard comes back in, and start to get a picture of how it looks currently at different trusts. I think that is me for now. So I'm going to pass back over to Claudia, who's going to talk through a little bit more detail about who the different stakeholders might be in the various different components that I just talked through.
Thank you, Katie. Yeah, so I think I'm just going to reflect a comment from Gemma in the chat about how there's, a medical gas committee who might be really supportive of the idea of decommissioning a manifold, but there's these difficult kind of challenges or perceived challenges, like identifying space for storage or doing something like a pressure test and there's no leaks revealed. And this is something we experienced over and over again throughout our engagement with trusts who have done this work. That often that kind of those barriers are the barriers to actually getting started. And I guess the way that we've shaped our advice throughout this webinar series is that instead of expecting your trust to fully decommission and get going with it, and also take the pressure test leaks data as the truth, actually we've flipped it to saying, go to your clinical areas first and talk to them about how much they use the gas, because often it's not much. And often, even if it doesn't reveal many leaks, you can be buying a lot of the gas and no one's really using it. And even that discrepancy should tell you, you need to align your system to what clinical use is, rather than kind of saying, oh, but the pipes are all good. It's like, but we don't actually need the pipes. And so we recommend not really focusing so much on the leak tests at this stage. It's actually about finding which clinical areas use it, how often, how frequently, and now let's change our systems, our supply systems, so that they match that use. And you can do that through a pilot, through testing, and we'll talk through all of that in our action plan and implementation webinars, where it goes into a lot more detail about how testing it and seeing how it actually is used and quantifying that can help you shift your system, and then you have that narrative for your medical gas committee. So that's, sorry, a little bit of a tangent, but it is relevant, because in the next slide we talk about some of the key messages that we think are important to get across to all of these key stakeholders. So Katie, if you can just shift to the next slide, please. Thank you. So as Gemma has mentioned, at the start of all of these projects, we've found that there can often be misunderstandings or confusion about the objectives that this project is trying to achieve. And this can lead to inefficiencies in the project's delivery and misaligned priorities across different teams. We've especially seen this between estates teams and clinical teams. So there can be a really passionate clinical team wanting to make this change, and they can be wanting they can not want the medical gas pipeline system anymore. But from the estate's perspective, it's like, well, we need this system to supply the gas, and that's the most efficient and effective way. And there can just be a missed kind of understanding in that. Equally, it can be the other way around, and clinicians can think or be worried about the gas being taken away. So the main things I think that we want to really highlight as the key messages and to overarch this project and these projects in both Internox and nitrous is that we want to maintain clinical choice. So we want clinicians to be able to access the gas when they need it for the patients that need it. And we want to assure that staff know that they can always access the supply that when they need it, and it's in a safe way. It's about reducing waste. So even if there's no leaks found in any tests, very often, I think pretty much in 100% of the cases that I've talked to, there's more gas being bought than being used. And so we want to reduce that waste because it's a volatile greenhouse gas, it's costing money, it's wasting resources. We want to reduce carbon emissions, which comes with reducing waste. And this is an unnecessary carbon emission. It's like having our car on idling for 24/7 when we don't need it at all. It's about increasing the efficiency of cylinder management. So we know that's part of the waste issue, is that there's just way more coming in than needs to be, and it's meaning that there's gas going around and kind of going through parts of the system and not being clinically used. So it's about streamlining that. And actually, it sometimes worries people that it's going to mean extra work for porters and facilities staff. But what we've found in all the trusts that we've talked to is that it reduces that workload. And then finally, reduce the cost of gas supply. So hopefully you're saving money in gas. We know it's not that expensive, but it is something. But it's also the maintenance of a kind of underutilized or unnecessary complex medical gas pipeline system. And this is particularly for places like ED, endoscopy, theatres, where we know that a small cylinder supply is likely to be much more aligned to the clinical needs. So we're just going to do a little game, bear with me. And it's just kind of thinking through some of the stakeholders and their interests and the enablers for them. So if you can use the chat just to answer the questions. So this person or this stakeholder contributes to the project by providing high-level support and ensures alignment with the trust strategic objectives. They are interested in reducing waste and the costs associated with maintaining inefficient systems. And they're also interested in achieving organisational targets. And they're enablers within the project. So what they will help with is strong leadership, dedication to sustainability. Who do we think that is? Oh, just realised I put myself on mute. Thanks all. So yes, it is C, the executive sponsor. So we'll just go through a few other key stakeholders. So another key stakeholder is someone who provides direct clinical aspects of the project and makes evidence-based decisions, ensures adherence to clinical guidelines, and supports changes and role models the new approach. And their interests are enhancing patient care, improving clinical efficiency, innovating and using best practices to improve. And then the enablers within the project are having clinical expertise, peer influence, and budgetary responsibilities. Thanks, guys. And I'm just gonna run through the rest of them because it's a fun game, but I think I talked a bit too much about the comment from Anita. So we've got lots of other stakeholders, like our teams who administer nitrous oxide in theatres. That is our anaesthetists and theatre staff. They're often really key influences in this project, especially in theatres. Obviously, but we've seen a lot of anaesthetists get involved in maternity settings and in pushing this forward in other settings as well. They become experts on the nitrous oxide system. We also have the stakeholders who collaborate with clinical leaders on strategies for reducing nitrous oxide waste. improve patient care and contribute to sustainability initiatives. And that's our other healthcare staff like nurses, midwives and dentists. We want to make sure that anyone who uses the gas is considered and involved in these kind of projects, because often they can be seen as, if it's not theatres, it's like, oh, that's too hard. But often you'll find a champion in these spaces. And then we've got our teams that oversee hospital infrastructure and equipment and manage the medical gas pipeline system. So they're really interested in enhancing the facility's efficiency, making sure there's not excess maintenance costs. We know that's a massive, challenge that we all struggle with, and adhering to guidelines like those health technical memorandums. This is our estates and facilities staff. They enable the team by having, good, really important technical expertise and implementation capabilities. We've also got our facilities and portering staff who manage logistics and movement of gas cylinders and ensure the correct storage and handling of nitrous oxide. They often know the hospital in and out and can really support with finding places like, where a sensible storage area might be, or setting up a process for how, if there's storage in the basement where the old manifold is, they'll be happy if they're only bringing up one cylinder every fortnight. They'll be more than happy to do that rather than switching over a whole bank of cylinders that aren't actually being clinically used. So really encourage you to get your facilities and portering teams involved in what that process might look like, especially in a pilot process where they can test out what works and what doesn't before switching off the manifold. You've also got medical equipment technicians who, or you might have a different name for them, like medical engineers or other kind of similar roles that work with suppliers of your anaesthetic machines and things like that, depending on your trust. But it's really important that the machines are all operating fine and that they're overseeing modifications to the supply system. Sometimes you might get random alarms and beeping and things going wrong, and you don't want that, and they can really help to make sure that's all going right. And then finally, you've got your pharmacy and pharmacy procurement team who often are buying this gas or might be part buying the gas and often also on the medical gas committee. And they have an interest in the safe and effective use of medicines. And so if you can reduce their costs, if you can optimize their inventory and kind of help them with those interests, then I'm sure that they will be on board. And they often have, the details of your procurement. They understand the costs and the volumes that you're purchasing. And they're often a great, starter for 10 to understand how much you're buying. And then you go and talk to your clinicians and you say, how much do you use this? And they say, oh, one case a week. And you can just see immediately that there's that discrepancy. So within all these stakeholders, and these are kind of the key actions that we'll talk through throughout the rest of the webinars, and we'll go into detail with them. But these are the key actions that we suggest for all kind of clinical areas in some way, shape or form. It might be a mixture of these, it might be one, or it might be all, or it might be two. So I think what's important is that all of these different steps require different stakeholders. So for portable cylinder systems, if you're switching over to a different system, then you're going to need to talk to your clinicians, obviously. You're going to need to talk to your gas procurement. You're going to need to talk to those technicians, and you're going to need to talk to your medical gas supplier to change what you're buying and talk to them about that and buy some of the equipment that's needed to make the modifications, which we'll talk through in another webinar about how that's actually a relatively low cost if you do it in the most efficient and effective way. For your decommissioning, it's really important to involve, just back, Katie, your estates teams, and you might have an authorised person or a PFI involved. And that's, kind of a whole different sub-process that's important to get right and take the steps through. And you might be decommissioning just a part of the system or all of your manifold, depending on which clinical areas, what clinical areas need. Then you've got fixing leaks, and that's at the point that we recommend doing a leak test. Only when you know you need to keep that system do we recommend actually testing for leaks and making sure that that's all in place? And there's kind of optimal ways that we suggest doing that, following the health technical memorandums, because we know there's some kinds of leak tests where leaks don't show up. And you need to involve your estates and facilities team, etc., in all of that, and your clinicians to know that they're not going to be able to access the system while it's being shut down. And then finally, you've got things like unplugging tubing, which can help you reduce waste in the longer term, and kind of modifying your equipment and changing it and being as streamlined as possible. And you're going to want to engage your clinicians on an ongoing basis in that. So all different points. You need to kind of carefully plan when and where and who and what. And as I said at the start, this probably feels very overwhelming, but it's just to say that there are lots of, experts to involve and include, but they do have a specific role throughout the process, and hopefully you can feel more confident in that going forward. So in this kind of process, and we've got, as Katie said, we've got some resources that will help you to do this. You want to identify and list all the relevant stakeholders across different disciplines. So just, figure out who those people are. And the medical gas committee is a great place to start, because often you'll tick off a few people in one go by going to them. The next is to schedule that kickoff meeting or go and see them, go and see the different stakeholders to introduce the project and its goals and align that messaging and make sure it's clear, what the intentions and what the reality is. And then finally, make a bit of a plan and consider how you're going to keep them engaged and keep them involved. Because of the multidisciplinary nature of this, it's unlikely you're going to be able to run a typical, weekly project stand-up or fortnightly project stand-up. Often it's a creative and, going to visit them in their place, or utilising the meetings that already exist. That really helps to drive this forward. So that's kind of my end point of how we involve stakeholders. I'm just going to hand over Julie to talk through how we actually influence these people, particularly senior leadership.
Lovely. Thank you, Claudia. Good afternoon. I'm Julie. I work for NHS Select and have been involved in many sort of large-scale improvement and implementation programs. So just sharing some of the experiences that I've had. It's really interesting. We talk about influencing people and trying to really think about this as this is going to be change. And people will be undergoing a change, and we're going to be seeing a diverse group of people that you're going to have to interact with and involve. And we really want to move beyond this sort of idea of the carrot and the stick of how we actually influence people's behaviour and get them to move forward with us on this journey. I want you for a second just to reflect on yourself for a minute and really think about when was the last time that you got on board with a new idea or change, and what influenced you, and can you write it in the chat? We have our own personal experiences, so what influenced you to change? If you can just write that in the chat very quickly. Yeah, if it seems relevant, outcomes seem valid, purpose of the change, understanding the why. It's influenced by knowledge and expertise. Yeah, some of the motivating factors. Sometimes how much involvement is needed, so potentially around how much time that you actually have to be involved. Yeah, and how people approach you in the first place. It's really, really important. I think what sort of is coming through is that there is definitely a diversity from each of you in terms of what's going to influence you and what has influenced you. And I think it's this understanding people's needs and building trust. And through that trust, you can lead to cohesiveness, and therefore you'll reap some of those benefits from it. And Patrick Lencioni, he talks about trust, and he says, with trust, people will engage in open communication, which will lead to further commitment and accountability. So we want people to take that equal accountability. So it's not just you as a project lead who is responsible for this, but that there is a mutual element of accountability and commitment for this change to reap its benefits. If you go to the next slide, please. As I said, as it's a sort of a change initiative, there are different models that we know that are available, and it's really is beneficial and helpful to use some of these frameworks. And this comes from McKinsey's influence model of leading change. He talks about they talk about four quadrants, and the first being around the fostering understanding and conviction. Got a few animations. If you move it forward for a second. Lovely. So the first one is around that fostering understanding and conviction, and this really is a step that focuses on creating awareness of the why nitrous oxide reduction is essential, and convincing stakeholders of this benefit. So if you can communicate the why, share data about the environmental impact of nitrous oxide, how reduction aligns with the NHS sustainability goals and net zero targets. Also around highlighting benefits, which someone mentioned. So use case studies to demonstrate how reducing nitrous oxide benefits patients, staff and the environment. Engage emotionally, so that emotional connection. So share stories or testimonials from healthcare workers or patients about their sustainable practices and how they've positively impacted them. And also involving stakeholders early. So we've seen that there is a sort of diversity in terms of people. So understanding those diverse mental models and mindsets, and make sure that you involve people quite early. And then we have the reinforce with formal mechanisms. And this is really making sure that your systems and your processes and your policies and your accountability measures are within the formal structures of your organization. So update your policies, introduce metrics so you can track usage and have dashboards to provide regular feedback to the teams. Use incentives, so recognize individuals or teams that achieve significant reductions and share those. And establish accountability, so define the roles and responsibilities for monitoring and maintaining those that reduction. If we look at the developing your talent and skills, so this is really important. Like I said, this is something that is new for some people. So do they have the confidence to actually undertake some of the recommendations or actions that you've identified? Sometimes that change can also be seen as a bit of a threat. So it might be a threat to how they currently operate and the practices that they're undertaking. So understanding from your initial work with stakeholders, what impact will this have on them, and how can we develop their skills to ensure that they can actually feel that they can be a part of this, building that sort of psychologically safe environment for people to develop those skills. And then if we look at the role model, so role modeling, this really comes from understanding that we watch people around us, we emulate their behaviours. So if we're thinking about our senior and executive stakeholders, so making sure that they are demonstrating the types of behaviours that we want to see in others, making sure that they're consistent in their messaging, and that we don't have too much conflict between one message saying one thing and one message saying another. So also recognizing that your role models are not necessarily always around the most senior people in the organization. They can be your more informal leaders. So role modeling is really a key social behavior that we see often. And so recognizing that each of our stakeholders is diverse, understanding what their needs are, making sure that we are aligning any of our formal mechanisms to each of those different stakeholder groups or individuals, making sure that they have the skills and the opportunity for support to enable them to do the right thing, and making sure that we're consistently role modeling that behavior across the organization. These are very sort of high level points, but I would really recommend you looking at a change model, because this is going to be a piece of change management that you're going to be undertaking for this project, and to enable this program of work to be successful. I'll hand back over to Katie. Claudia.
Thanks,
Thanks.
Julie.
Angeline, I wonder if you would be able to share kindly a couple of links in the chat that just relating to what Julie was saying about case studies and experiences and examples of where others have done this work. And one of the links is the consensus statement from the Royal College of Anaesthetists that Angeline's kindly going to pop in the chat, which states quite openly that the college advocates for a movement away from piped nitrous oxide in the theatre setting. And another is a graphic which illustrates all the different trusts that have done this work, both for nitrous oxide and for nitrous oxide oxygen, with a little bit of information about the savings that they've made in terms of volumes of gas and litres as well, and emission equivalent. But obviously there are more case studies available on Green NHS website as well to help build that case. Sorry, Claudia, carry on.
No, that's okay. Thanks, Katie. Cool. So yeah, hopefully those materials can help with the influencing. But also there's going to be a lot of guidance throughout the webinars, just to plug them again, about some of the challenges that you might have in helping to overcome them, and some of the perceptions and understandings of things. So stay tuned. Cool. So now we're just going to quickly go through, before we go into some real world experience from Laura and Max, into some of the tools that we've developed to help you get started. So these are available now on the NHS Future page. And if you don't already have access, then go ahead and sign up, and I'm sure Eleanor will grant you access. And Katie's just going to take us through kind of how you navigate it. So once you've gone into the NHS, the Green NHS Knowledge Hub, you should be able to find the draft supporting resources that we've developed as part of the toolkit. So there will be formal published versions at a later date, but these are kind of the draft versions because we wanted you to have access to them now. And I'm just going to go through some of the key resources that we think are helpful for getting started. And there's others that are in here that might be useful at a later point. So the first resource that we wanted to talk through is the project management portfolio. So Katie's just going to show you that once you're on the page, you can click. Oh, where have you gone?
Oh, sorry, I didn't actually show, but if you click on that, it will take you to a page and you'll be able to download it directly off that link. Sorry, I had one I prepared earlier, which is on the screen, but you will be able to download it by clicking on that link.
Thank you, Katie. And this is basically a template for your project that has some pre-populated bits and some kind of not populated bits. And you might have your own version of these in your trust. It's not intended to be something you have to use, but we just thought it might be helpful to give you to get started. In particular, so we've got all the tabs down the bottom, and there's a cover page which kind of explains what this resource is for. The stakeholder list is somewhere where you can list all your stakeholders and all your contacts. But the stakeholder engagement plan is the one that we have started to populate to help think through what the messaging might be. So, for example, you might have the audience of your estates and facilities team, and you might want to mention to them that you are transitioning to a portable cylinder system, and that you need to decommission the pipeline. It's kind of framing it in a different way than, hey, we need to check if there's leaks and stuff, and then we'll decommission. It's, we need to align this to clinical use, and this is what it means. So that's, for example, one of them. You've got your pharmacy procurement team. It's about requesting small cylinders, things like this. And obviously this is just things that we have thought might be helpful messages, and at which point as well. So actually at this point, we've only really recommended creating the project on a page, which is another resource we have at the get started point. And we've also recommended who kind of should do this. And you can edit these, change them, and use them as you please. So that there's also down the bottom other tabs that hopefully would be helpful in your project. The second key resource that you can download from the website is the action list tool or action checklist. And Katie will just bring it up in a minute. But basically, it's developed based on insights from other trusts. And again, not prescriptive at all, but can just give you a bit of a guideline as to what steps you need to take. And it's quite detailed. And so how it works is at the top, you've got your phase that you're at. So we want to get started. We want to ensure the supply of gas is aligned to clinical use, or we want to continue to optimize our system. And obviously we're at the get started stage. And then we need to, the second step is, you can filter it down more, and then you can also filter it down by role. So what happens when you click on these kind of filters is that the list below, which is just here, kind of shortens down just to the key parts. And then you can use this to track which actions you've done and not. So you can put roles in, owners, due date, and status. And hopefully this can help to just take you through some of those steps. And basically what we had on the slides at the get started point is what kind of comes into play here. So that is a resource. And as I said, you can edit the checklist and change it to suit your needs for your trust. Yeah, and then the third one that we hope is helpful is, so the key action checklist, this will be on the NHS Futures page, which we can the Greener NHS Knowledge Hub has a specific page for the nitrous oxide waste mitigation space. Yeah, so you should be able to access it there. And this is the final template that we think is useful for this stage of the project. And it has quite a few different little resources in it. So it's basically just comms drafted for you for your project. Again, you can edit it, it's editable, you can make it work for you. And it includes the project on a page, which we already have completed kind of some of the key aims and objectives, so you don't need to reinvent the wheel. It's pretty much the same for this project at all trusts. And then there's kind of parts of it that you can fill in relevant for you. But you might also, have different objectives and aims, and that's completely fine, obviously. But this is a resource that we think is helpful to just really get your project, what you're wanting to do, what you're wanting to achieve on a page. And also within this, that's okay. But there's some other parts like draft emails and thanks, Katie, and a draft survey. So some of those things I was saying earlier about just asking your clinicians how much they actually use the gas is something that can help you know what you need to do next, which we'll talk through a lot more in detail in our next webinars. There's also some frequently asked questions. So how do we know we're losing large amounts of nitrous if our tests don't find leaks? There's answers similar to what someone mentioned in the chat earlier to that question in here, and other kind of FAQs that we've found have come up. And this can be helpful to kind of set that intention and that overarching alignment of different teams and kind of squash some of the misconceptions. So those are some hopefully handy dandy templates and resources that you can use, especially if you haven't gotten started at all and you don't know where to start. And hopefully it will save you a few hours pulling together stuff that we've already done and then others have already done. So what we're going to do next is probably the most helpful part of this whole webinar, and it's to share with you some case studies and introduce some of our colleagues from trusts who have done a lot of work in this space and are champions in this space. So I'm going to invite Laura from King's and then Max from Cambridge to speak through some of their experiences within the context of this webinar particularly. Thanks, Laura.
Thanks, Claudia. Hi, everyone. Yeah, so as Katie's already mentioned, I work at King's and we used to work together, which was lovely. So actually started this project together, both of us fairly clueless. So if you do feel a bit like that, do not worry, because we were exactly the same. And as Katie said, that first manifold walk around was so helpful because I didn't know what a manifold was. So it was really nice to see one in the flesh. So by all means, no one I think starts this as an expert. So yeah, it's really good to start off, as you can see here, by building your multidisciplinary team. It's probably the most important thing that I want to mention, because we actually faced a huge amount of nitrous oxide waste at King's. So actually 90% of our nitrous oxide was being wasted. So you probably see really high figures when you look into things like this. It's always in the remit of like 80 to 90 something percent. And we actually really lowballed and said something around in our very initial data planning, and then we were quite shocked by the 90% waste, which is around 900,000 litres. That is a lot of gas. So yeah, when Katie and I first started, the things that we wanted to do was obviously get the right people in the room. So I'm a pharmacist, so that was Tick from pharmacy, and then Katie was our corporate project management, which is great, but obviously we also had to have theatres, anaesthetics and estates colleagues to help with this as well. So we started really small, and we wanted to focus on, so King's actually is a really large site. So this is just did one site to start with, which is the Denmark Hill site, which is the one in central London. And we had 5 big nitrous oxide manifolds. So we wanted to do it in like sizable chunks. So we started with one manifold, which was quite small and actually had like basically no clinical use. So that was quite good, because it helped sort of prove get us starting small and are able to adapt our approach with that. So yeah, we used our liver theatres manifold as our first challenge, and within 6 weeks of the project we'd actually decommissioned our first manifold. So that was really good, really helped with morale. And I think the key to this is definitely like having a strong project team and a strong governance, but also things like regularly updating the people who were in the know. So people like our medical gas committee, the trust sustainability committee, and executive leadership as well, which Claudia and Katie have touched on. It's so important to make sure that those people are chimed in with you, because all trusts have to have a sustainability executive lead as per your green plan. And this is the person that can support you, and they can open doors for you and unblock challenges, because they are very senior and that is what they're there for, to support the sustainability agenda. So yeah, we were also able to use this then to get like airtime in the trust as well. So like we're giving the project kind of the attention it needed. And from that, and from the help with our sustainability and medical gas committee, we were able to get an initial small amount of funding to buy the trolleys and pressure regulators which were needed for that first manifold, which was that liver manifold. And then we actually were able to apply for a grant from the Greener NHS's Healthier Future Action Fund in 2022. So this was great, and obviously the funding helped us be able to move this project along, but we wouldn't have been successful in getting this if we hadn't already formed our project team and started to understand the size of the problem we face. So having that data around how much wastage we knew, doing our own clinical audits, and already having that idea helped us build that proposal. So yeah, discussed about the exec leads as well. And so yeah, basically all there's left to say is that we've now decommissioned 4 manifolds. Like I said, we have 5. We've decommissioned 4 of our nitrous oxide manifolds and downsized one, which we basically halved it. So we still have a small manifold that feeds our dental unit, because it provides other challenges. But yeah, we've reduced waste, costs, carbon emissions, and I'm hoping this case study does kind of show how like a phased approach with governance and collaboration can achieve impactful results.
Thank you so much, Laura. And we'll have a little bit of time for questions at the end, so hopefully Laura will be here for that. And then Max, over to you.
Hi everyone. Hello. Thanks for giving me the opportunity to talk. Yeah, so it's pretty similar to the other hospital. But basically, yes, we've just got confirmation through leak test detection, basically, that we were wasting about 98% of our nitrous. So we are a large trust with 3 manifold sites. So as of last month, we are now completely manifold free. We moved away to mobile cylinder across the whole site, which is a very big success for our team and for the trust, to be honest. That means I don't really remember, but I think it's 2,500 tons of carbons emission avoided every year. So that's the equivalent of driving more than 700 times around the Earth every year. So that's just for some gas basically that we're not using, just wasting. This is tremendous in terms of carbon targets, which is good. Which is why everyone should try and do the same. I think in our case, we didn't have an official multidisciplinary team. We had one project manager, if I can call myself this. Basically, they ended it on my lap about 2.5 years ago, and I worked with some very kind colleagues who gave their free time to make this a reality. Because even if we were endorsed by executive and the board on our green plan to reduce our nitrous oxide consumption, there was no real airtime or allocated free time for the staff to work on it. So, well, we had to, make it work one way or another. So basically, a lot of people just gave their free time or carved out 10 minutes out of their busy time to, make this a reality. So I just want to say to people thinking, oh, we're not going to get the help or the governance needed or all of this is still feasible. It will take a long time, depending on how persistent you are with your colleagues. But it can be done. It can be done even in a trust as large as Cambridge. We've done it. So you can. It's just it's going to be a long process. I imagine longer than if you have like the whole support and a proper official team in place. You just in that case, you just need to find the right individuals and get them to do their bit as much as possible, basically, out of goodwill. But this is feasible. We're still reporting every quarter to the medical gas committee. We had a 5-minute slot in the busy agenda to just say, yeah, we've done this bit over the last 3 months, so they couldn't make a note of it, really. And then we try to find funding basically from medical gases budget, because if we were saving at 98% of the gas, that means 98% of cost savings as well. So we use this. So that but to be honest, funding was, in the grand scheme of things, I think we used less than 10k to get this done. I mean, maybe 15. So it's in the hospital budget, that's nothing. I mean, so and now, so yeah, as I said, we've decommissioned 3 manifolds, and we are okay. And